Nicole Relke, who's Dr. Nicole Relke, who's in her first year of the transfusion medicine physician training programs at the University of Toronto. She obtained her medical degree and completed internal medicine residency at Queen's and hematology residency at the University of Toronto. She's got an interest in quality improvement and clinical interest in the management of immune cytopenias. And I'll just call out, Nicole, I know my understanding is you picked up a bit of an illness. So I just want to thank you again for taking the time to do this talk with us.
Of course, yeah, no, just a little viral thing. Figured I wouldn't be patient zero and infect everyone at the conference. I'm happy to be here and thanks for the introduction. Just want to confirm my slides are okay. Everyone can see them?
Yes, we can see them.
Okay, perfect. So I'm Nicole. I'll be doing the first case presentation. I just want to start by thanking Christine, who actually gave me this case that she had last year. And I will get started. This is a case of Miss R. She's an excuse me, 88-year-old woman with a history of LGL, that's transfusion dependent. Otherwise, she has aortic stenosis, moderate to severe hypertension and anxiety with a remote hysterectomy. She's on prednisone chronically to manage her LGL and some other medications detailed here. Her transfusion history is such that she's gotten a unit of red cells every 2 weeks since April 2021 for her LGL. She had an anti-cal detected in May of 2021 in a warm autoantibody later that year, although this wasn't known to the UHN blood bank at the time of her presentation. She's group B positive, and her red cell genotyping is R1r and obviously cal negative as shown here. Like I mentioned, when she presented to UHN, she had a negative antibody screen. Miss R was admitted to Toronto Western Hospital for 2 weeks. She had a fall and separated T2 compression fracture. This was managed conservatively. On April 29th, she received a 1-unit red cell transfusion for a hemoglobin of 62. You can see that she had a great increment and there was no reaction reported. She was doing well and was actually transferred to rehab. And over the next 2 weeks or so, she had a slow trickle down in her hemoglobin to 59. And so the team at rehab did order 2 units for her. They did upper and lower endoscopies, and there was no evidence of bleeding. So this was attributed to her LGL. And I think she was otherwise asymptomatic at the time. They astutely did recognize the TACO risk in her, being 88 with severe AS. And so they did pre-medicate her with Lasix 40 milligrams. It was orally ×1 prior to the transfusion. The onset of oral Lasix is 4 to 8 hours versus about 5 to 10 minutes for IV. They also ordered the unit over 3 hours, each of them. On the bottom right, I've just shown the dates, the group, and the cross-match method for each unit. You can see that the second unit was nearly expiring, day 42, and both were electronically cross-matched as per UHN, the patient had no known antibody history. This is a graph of the patient's vitals. You can see her systolic blood pressure on the top, heart rate, temperature, and SpO2 on the bottom, and this is based on time. On the top here, I've written out the vitals. So you can see that she got 40 milligrams of oral Lasix to start, and unit 1 was initiated. It was actually run a bit more than 3 hours, over 4, but you can see no signal of change there that we're worried about. By the time unit 2 has started, nothing is standing out as a red flag, but you can see that the blood pressure systolic is starting to increase as the SpO2 is starting to decrease, but not enough to warrant concern. Unit 2, like the first, was given over 4 hours. And at the time of completion, there was no vitals available, but shortly after, post-transfusion vitals revealed a fever, 37.9, with associated chills and rigors, so classified as a high-risk fever due to symptom presentation. The oxygenation was borderline hypoxic and the blood pressure continued to rise. This prompted a call to the blood bank to alert them of a febrile transfusion reaction. Shortly thereafter, about 20 minutes later, fever over 39, overtly hypoxic at 86%, and thus oxygen was applied, and you can see that the blood pressure is even higher. The patient was not tachycardic, but you can see that there is a slight trend upwards over the course of the 2 units. Because the patient was in a rehab facility, she was transferred to the emergency department. So in the ER, she remained febrile, but interestingly on presentation, her blood pressure was 100 systolic. So was more hypotensive. She remained hypoxic on 2 liters. Because of the fever and the hypotension on presentation, she was empirically treated for an infection and given meropenem. She was given 1 more gram of Tylenol on arrival as well. The fever and hypoxia were actually quite short-lived in the emerge, only lasting about 2 hours. This is her x-ray. You can see that there's some evidence of bilateral like increase in volume. There's some curly B lines and some congestion. But on top of that, there's some superimposed airspace opacities in the perihilar region, and especially the right lower lobe here. The radiologist's conclusion was this looks like congestion or edema, but TACO or Charlie cannot be ruled out. In terms of her physical exam, the patient did have an elevated JVP per the consult note at 3 centimeters. Interestingly, her RESP sounds were clear. There was no reported crackles or wheezes. She did have +1 peripheral edema, and I could not see from the notes if that was new or old. In terms of her blood work, she had a BNP that was high in the intermediate range, although there was no prior for comparison, and she had a trope elevation up to 1,000. The 58 was about a month before this event and during her original hospitalization, and that I think is probably a steady state troponin for her. We didn't have one immediately prior. And because of the elevated trope and the chest pain symptomatology, she was treated as an N-STEMI, given aspirin to chew, and admitted to cardiology. I will mention that the ECG was normal sinus with LVH, no ST or TUA changes. In terms of transfusion medicine testing, the patient is B positive CalNeg. The first unit was typed the same, and the second B neg CalPos. Her antibody screen pre and immediately post were negative, and the DAT post was negative. You can see that she had no biochemical evidence of hemolysis as well. And so there doesn't appear to be any evidence of serologic incompatibility. The patient had blood cultures. 1 of 2 were positive for coag-neg staph, which we know is likely a contaminant. And unit 1 and 2 are both culture negative. This reaction was sent to CBS, and they looked into it from a donor side, and they said that both donors were not implicated in any other adverse reactions. And this reaction occurred in the pre-pathogen-reduced platelet era, and so they let us know that both platelet co-components were also BAC-T negative. So I just want to pause here with that information. I'd like you guys to answer the question, what is the conclusion for the adverse event? Do you think this is FNHTR, TACO, trolley, TAD, or bacon, if you have to choose one? Just give everyone a minute. I'm not sure if the poll is supposed to pop up. There it is. Okay, perfect. I hope everyone can see that. I can. Interesting. So we have the most common vote being TACO, about 20% for FNHTR and 20% for trolley. For those that did not choose TACO, does anyone feel comfortable kind of explaining their choice? Feel free to just chime in. I think it's an interactive discussion. No one. Okay, no problem. What we did concluded for this case was taco per the majority. I can see the reason why you might choose FNHTR because the presenting symptom was fever, and we'll talk a little bit about that. But in terms of the taco criteria that this patient met, they have the respiratory distress. They have chest X-ray evidence of some edema and venous congestion. They had elevated JVP and peripheral edema, and also an elevated BMP. So we felt that taco was the best fit for this, given the symptoms and the hypoxia as well. In terms of the relationship, now talking about taco, what do you think would be the best relationship for this event? Definite, probable, possible, doubtful, or ruled out? Awesome. So probable, that's what they concluded as well, both CBS and the blood bank side. And the reason for that, I think you'd agree, this is a bit of a muddy case. There's a fever as a presentation. There's a 1 out of 2 positive bacterial culture. That's probably a contaminant. But I think the biggest thing for me was the opacities on the X-ray. Could this have been a presentation of pneumonia with an aspiration and TAD? Some volume overload component. So I think it wasn't a slam dunk taco, as most cases are not, and probable was the most appropriate designation. And what would you classify the severity of this case, knowing the information presented thus far? Awesome. So severe, totally agree. So this patient had to leave rehab and present to emergency department for care. I should have put this at the end, but this is about the outcome of the adverse event. I'll just tell you that it was minor with no long-term sequelae. And I'll wrap up the case in a minute. But this is a bit of a quiz, I guess, from Christine's talk. But why don't you guys tell us how often does taco exhibit fever, or hot taco, as Christine put it? Okay. 10% and 30% have equal votes. So I will just bring up the study from Christine and Jacob and Lanny and Yulia and others. This was their publication looking at hospital hemovigilance data. As Christine mentioned, they looked at about 100 taco cases, and they did exclude those with pre-existing fever. And they found in their data that 30% of cases of taco had new and concurrent taco with fever. And interestingly, you can see it was fairly split as to what the referral trigger was. It was half fever and half dyspnea and hypoxia. And so our case, the first trigger was fever, but then things evolved to dyspnea and hypoxia. And as Christine mentioned, they were looking into, was this a problem with the age of the patient in terms of their atherosclerosis? Was it a red blood cell product age problems like FNHTR? That didn't pan out. There was no difference in host age or red blood cell age, and actually no difference in severity of transfusion reaction. So just to wrap up this case, it's favored hot taco. You just report taco, of course. But I do appreciate the votes, which was, could this have been an FNHTR event like this presented with fever? The second unit was 1 day from expiry. We know that that can lead to FNHTR. I don't think we can ignore that this patient does meet taco criteria and is an at-risk patient, being elderly with aortic stenosis. And I mentioned as well that something else to consider would be TAD plus another unrelated event being pneumonia or aspiration, given the chest X-ray findings and a bit of evolving hypotension, which could have been an early sepsis presentation in the emerge. So to wrap up this case, it was classified as a minor because the patient did well. They got 5 days of ceftriaxone. They actually got a cath as an inpatient and had normal coronaries. Cardiology thought that the demand ischemia or the trope rise was demand ischemia from fever, tachycardia, and AS. And so they were admitted for 6 days and ultimately discharged back to rehab, and they actually underwent a TAVI later that year. The blood bank provided some future mitigation recommendations. So pre-transfusion Lasix and maximum allowable duration, which the team did. But I think the biggest thing here was to provide a single unit at a time. And just some take-home points. I'm happy to hear other people's thoughts about the case as well. This was a complex reaction with quite varied symptomatology at presentation. And I think this case illustrates nicely why we cast such a wide net in our investigation of transfusion reactions so as to not miss something in our differential. Some interesting complexities I did not discuss. This case was one that seemed to keep on giving. The patient expectedly developed a DSTR from the reactivated anti-cal a few days later, but no hemolysis detected. And interestingly, when this case was investigated, they found that the first unit was actually plasma volume reduced twice. And so there was some discussion around would that have been more hemoconcentrating? Did that further increase their risk of TACO more than a single PVR? And this was concluded not likely to be the case. And one of the biggest take-homes of this case would be to recognize hot TACO, about 30% of cases. And lastly, our role in reminding clinicians of the choosing wisely statement recommendation to avoid a single unit when appropriate. So in this case, stable, non-bleeding patient with chronic anemia, 1 unit may have been more appropriate and perhaps could have led to a different outcome. So that's the end of the case. Happy to hear people's thoughts. Christine, if you're still here, if you want to chime in as well, as it was your case. Thanks so much, everyone.